that can be very complex. In the interest of time, we'll keep moving forward. I'd like to invite Dr. Linda B from the USA as well, who will present on integrating research with a career in skull-based neurosurgery. Thanks so much, Dr. B.
Thank you so much. An honor to join this group on such a packed agenda day. Um, Here we go. And share. Wonderful. Well, I'm delighted to talk about this topic in the midst of so many expert surgeons, because I think that often, as we reflect on the rapid evolution of neurosurgery over the past century, it really is because of a collective thirst amongst all of us to drive innovation in concepts and techniques, as well as in technologies, and for us to reflect on mistakes, identify areas of improvement, and understand the natural history as well as the unnatural history of pathologies. All these efforts, I think, converge on research, whether it's research on operative techniques, as we've heard, on access and delivery about care, imaging, biology, outcomes, and one product of that research is scholarship. But the other project is fundamentally the evolution of neurosurgery and skull-based surgery. And for me, this is a 4 weeks in a previous year when I did not travel. And so, as a skull-based surgeon, most of our time, for most of us, is spent on surgery. And the risks that come concordant with pathology such as this, in order to give each patient what they deserve in terms of maximum quality, as well as durable effect of a tumor resection, was not to be belittled. It's something that requires all of our effort and intense time. And so time then becomes the greatest commodity in all of our lives. And to then think about why we would possibly spare the extra weekends and evening hours when we are already so invested in the excellent outcomes of our patients to do research. I think about it in one of two ways. One can either think about it as a service or as the impact, leaving behind a little something for the world. On those elements of our practice, which includes patient care, investigation, with teaching and mentorship straddling these two buckets, falls somewhere between these two elements. So if we decide that we would like to spend some time on research and on the honest introspection of improving our field, what is it that would be best to spend our time on? Well, this really puzzled me for quite some time, recognizing that I will never have the bandwidth as the amazing scientists who are discovering new modalities, left and right in our medical domains. But I think one of the unique privileges of being a surgeon is that we have the access and insight about patient needs, and to have patients serve as a basis really formulates an amazing opportunity for all of us. I'll give a few examples of this. For me, half of my practice is in skull-based tumors, and the other half is in deep-seated intraaxial tumors. And for these tumors, especially early on in my practice, in order to be able to consistently offer surgery and to have a high level of confidence that the patients, especially in malignant tumors, will do well without surgery and delaying a potential avenue forward to chemoradiation, means that we need things to help us. And for us, that meant an evolution in our intraoperative neuromonitoring techniques, not only in what has been discussed before, but ways of optimizing that, including an evolution in the technique for cortical bulbar evoked potentials, as well as the identification of brain sag physiology changes. In other words, having the daily practice become a laboratory to address clinical needs, that just because we use what has been reported before, it doesn't mean it can't be better. And that it's sort of a reflection from case to case, as well as looking at global results, really, I think, serves as one key opportunity for neurosurgeons, especially skull-based surgeons. Another comes into the category of patients who have aggressive pathologies, no matter what we do, such as this is a malignant meningioma that no matter how many times we do surgery, it escapes our control. And so part of our hospital's name, Brigham and Women's Hospital, the women's part of that name represents that 5,000 babies are born in our hospital. And so every one of those babies gets tested for trisomies and for other chromosomal abnormalities. So we took that opportunity to apply these sort of testing to meningiomas because it's long been recognized that chromosomal alterations are a basis of meningioma behavior and biology. And over time, about a decade's time specifically, The greater than 1,000 meningiomas operated here allowed us to collect the biology from these and to make an integrated grade, what we call a molecularly driven grade for meningiomas, to supplant the 3 grades of the World Health Organization. This is not meant to create a divide between those who have access to genomic platforms and those who do not, but simply to improve what we can do. And the reason why our hospital was able to embrace this quickly is because of the single slide in which you can see that those so-called malignant tumors that were molecularly benign in the blue did a lot better over long-term follow-up than those so-called benign tumors that were molecularly aggressive in red. And so this is an example for us of using available translational biology to address unmet patient needs, to be able to better identify those patients who are going to recur and who need additional treatment. But recognizing that biological platforms are not globally available, we do a lot of work in making them scalable. But beyond that, even if a particular hospital or lab does not have access to look at genomic profiling, most of us who operate on a tumor have access to an MRI to be able to operate on that tumor. And so the field of radiomics is yet another that's exploding to be able to take the embedded quantitative imaging information that's within the MRI and to recognize that there is often a phenotype genotype link, and then to take those imaging features back to the early operative decision making and maybe to infer even more about the pathology and the genomics of the tumor. In short, I think that we all have an opportunity to develop expertise driven by unmet patient needs, and there are many of those, and also to gain inspiration from other domains. And what that means is that to be able to elevate the knowledge gained honestly and iteratively, we need to understand what is unique to our practice, such as the fact that we may have a particular access to a data set, such as for us in the genomic information, to a skill set, to personnel or funding or ideas, and to be able to identify the right partners, which may or may not be within medicine. For us, for example, a key partner in medical illustration comes from a neighboring school of fine arts. And so we all have unique assets in our surrounding community. And to be able to allow that cross-fertilization across these disciplines, including industry and across school departments or even schools of thought, as well as patients and our advocates, really allows us to then foster the honest introspection of our learning. And I think that to me is what research means in the field of skull-based surgery. So thank you very much.
Thank you, Dr. B, for this wonderful talk. And I think it opens our eyes apart from just surgical nuances. I think the floor is now open.